Welcome to ePathshala today, and under the topic of social medicine and community health, we've been discussing healthcare delivery systems. The first referral unit is going to be discussed today. Thanks to the guidance of Professor Vidya-mitra and his team from Aligarh Muslim University, who have prepared this lecture and material for you students to learn. Now, most important, let us start with the objectives. What do we intend to learn and to get once we finish this lecture? And that is to understand basis of the referral system in healthcare delivery system in India, to learn three critical determinants of a facility being known as a first referral unit, to learn essential services being provided by FRU. What is FRU? FRU is actually a first referral unit, and we are advocating safety for the mother, safety for a baby, and real-time visibility and operational efficiencies. So, and this only means that if at the field level personnel we have a patient or we have an individual or we have a child in difficulty, the first means of how to transport or how to improve her condition or his or her condition, and how to see that the person gets primary and essential care at the fastest speed possible, whether it be at home, whether it be in the hospital. And now this concept of FRU was advocated actually with a view to provide referral health care for cases from the primary health center level and for the cases in need of specialist health care approaching the center directly, with special emphasis on emergency obstetric care. So in other words, we have to know that the patient is normally visiting from the village to the primary health center. From there, the patient reaches the primary health center and with the help of the ANM or with the help of the Anganwadi worker or even with the help of the other field level workers who are working there. So it is from there that the services for referral starts taking place. So what is the first place to go? And the first place to go, that is the first referral unit which should come to mind from the PHC level, is the CHC. And at the district level hospital and the other facilities available at the district. In other words, in 1992, the Child Survival and Safe Motherhood Program, with the assistance of the World Bank and UNICEF for upgrading the existing CHC and the sub-district hospitals, was created. A number of steps have actually been taken under the Reproductive Child Health Program for facilitating the operationalization of these FRUs. And these have included actually operationalizing, OTs, and the labor rooms and supply of equipment kits, drug kits, hiring of anesthetists from the private sector, setting up blood storage units. In other words, we should have from the referral unit itself, we should be able to have a whole team at the end of the mobile or at the end of a call, so that in case the anesthetist is not there, the surgeon is there, at least he or she can be called straight away in order to help the patient. Then of course we have the blood storage units, because we can't have a blood bank, but from the district the blood may be stored in blood storage units at the community health center. Despite all these efforts, actually not many FRU, that is first referral units, identified by the state governments have actually become fully operational for a provision of 24 hours emergency obstetric child health care services. Now, this is why this CHC was set up. It has an OBG person who is posted full time there, along with a medicine person, with a surgery person, and an anesthetist, and of course there is a doctor from the Ayush also. But our main purpose is to deal with the emergencies arising in the village, and the first emergencies which comes to mind are the OBG emergencies, that is dealing with the emergency obstetric and child health care. So for this, we must be prepared. Unfortunately, many of the FRUs, as has been identified, are not exactly working 24 by 7. And therefore, it is essential that the state governments must make them fully operational for a provision of 24 hours service. Now, in the 10th plan, plans have been recommended, and in the 10th plan, actually, the identified establishment of fully functional and operational FRUs as a priority area for the provision of emergency obstetric and newborn care have been done. But they have to be fully equipped, they have to become fully functional, and emergency provision of the surgeons, of the personnel, of the equipment must be done. By the end of the 10th 5-year plan, each district should have at least 3 or 4 functional facilities which are equipped to provide emergency care on a round-the-clock basis. So that means the staff must be on duty 24 hours by 7, the doctor must be there, the anesthetist must be there, the OT must be ready, and the OT staff must be ready, and in case it is needed, the X-rays and the laboratories must also be ready. It also now as part of the 10th 5-year plan, because we want to make this place absolutely ready to provide emergency care. So actually what has been done is mapping of each CHC area of the existing health services, available manpower and other resources for each district has been done and is being done also, because it's important to know what do we have in hand which we can utilize. Besides that, whatever we have, either the trained manpower, they must have proper training, proper equipment, and sterilization complete. We must take care of. Now, what is the definition of FR? Actually, you can't create an FRU as such. There has to be a prior structure on which we create a first referral unit. So, therefore, there will probably be an existing facility, that is the district hospital or the subdivisional hospital or the community health center, and once they are fully declared open, they can be declared fully operational first referral unit only if it is equipped to provide the clock services for emergency obstetric and newborn care, in addition to all the emergency that any hospital is required to provide. Now, if we want to have an emergency obstetric and newborn care, it means that the beds must be ready, the pediatrician must be there, the anesthetist must be there, and all the other facilities which round up the complete provision. But it is not only the community health center which can act as a first referral unit, but the subdivision, if there are nearby subdivisional hospitals or the district hospitals and they are on the route and they can be approached easily, so it is possible that they themselves can act as first referral units. So not necessarily, because district hospitals, subdivisional hospitals, they will have the doctors, they will have the trained personnel, they will have the OT requirement, and instead of focusing only on community health center, we can focus for services, for good services on the district hospital and subdivisional hospitals also. Now, you can see a very nice picture of Samudayak Swasth Kendra at some place, and this photograph, you can see that the hospital is a very well-built hospital with platform for carrying wheelchairs and for the stretchers which can be taken into the wards and into the OTs very comfortably. And I'm sure this seems to be a very well-equipped hospital. And this is actually where we want. In fact, this is a picture of the CHC Jawan Aligarh working as a first referral unit. And most important is that the um, um, approach. Now we can see here there's a beautiful road, although it seems to be on the baseline of urban and rural areas definitely, but you can see that the road approach is a very good approach and the hospital seems to be have been kept clean and good. Now what are the requirements of a first referral unit? Most important is the emergency obstetric care, including surgical interventions like cesarean sections, newborn care, blood storage facilities. These have to be there because a woman can come with placenta previa, she may deliver, she will need blood transfusion, and of course, there has to be a 24-hour delivery service, including normal and assisted delivery. As by assisted, we mean it could be a forceps delivery or it could be the episiotomy. Person might need episiotomy, and of course, at the end, in case there is difficulty in the delivery, then we can go on to having cesarean sections. Emergency care of the sick children must be taken care of. There is a full range of family planning services, including laparoscopic services for those women who are coming for a normal delivery and with the requisite number of family for children in their family. They could even go in for laparoscopic services and laparoscopic sterilization. Then most important is the safe abortion services. Today abortion has become a service which can be self-requested, and in case but depending on the term of the pregnancy, and if a woman does not want or it is medically contraindicated, these abortion services have to be rendered with complete safety and with complete compliance. Then most important, treatment of sexually transmitted infections and RTIs. And people may come with fevers and with the local complaints, so they have to be treated. But this in treatment of sexually transmitted diseases, it is not necessary that it is not only that the person is examined and the treatment is given. What is more important is the second part which follows a treatment of an STI, that is, you have to take a proper history of their contact history and of their circle history. So because it is not only the treatment of this individual which is essential, but it is the treatment of all those individuals directly or indirectly connected with our case who has reported today. Then most important, essential laboratory services, because either it could be blood, urine or any of the other services, and X-ray services. Then referral and transport services are a must, because there must be a 24/7 ambulance service, and it is critically important that we should be able to transmit these cases very safely and within a short time, within the required time, to the higher hospitals in case it is necessary. And it should be noted that there are three critical determinants of a facility being declared as an FRU. First referral unit, that is, availability of surgical interventions is a must. We should be able to do surgery, offer surgical interventions, and that too emergency interventions at the center. We should have newborn care. In other words, we must have an incubator, we must have oxygen, we must have a pediatrician who should be able to look after that baby, and we should have a blood storage facility on a 24-hour basis, because in case any patient could need, either a baby might need, a bleeding mother might need, or even an accident case who reports to these centers might need. So therefore, blood storage facility, they must get all types of the groups from the districts, and they should be able to store on a quick basis and provide as and when necessary. This is very important point. Now, what is the basic referral service? India actually has a three-tier referral of healthcare delivery system from the sub-center to the PHC, at the grassroots level to the medical college and the apex institute at the top. So, in other words, the patient starts from his village to the sub-center to the primary health center and finally to the CHC, and then it goes on to the district, and then it goes on to the tertiary level of care, that is the medical college and the apex institute at the top. And this is important to know because since your referral units are also acting as reference for handicapped people, so operative procedures will take planned operative procedures will have to take place only at the apex hospitals or at the medical colleges instituted by the government to cure and to help deformities or readily correctable deformities as a result of injuries, as a result of accidents, or as a result of leprosy also. Then the sub-center is the most peripheral health institution available to the rural population and it stands at a population of 25 to 30,000. It functions as a first contact between the community and the healthcare provider. Like I said, the sub-center has actually 30,000 population. And under the sub-center, each one will have its each will have its 5 villages, and each of these villages approaches to the sub-center from where they finally go on to the PHC. And it actually functions as the first contact between the community and the health provider because it is situated at the very village level itself. And it is staffed by the regular number of healthcare providers in terms of the Anganwadi worker, in terms of the ASHA, in terms of the traditional birth attendant, and also in terms of the village level worker, village health guide. Now, PHC, Primary Health Center, is actually a referral unit for 6 sub-centers. Like I said, it has a population of 30,000. Now, in this 30,000, each village has a population of 1. So, from the primary health center to the sub-centers, so each one will have about 6, that means about 5 villages per sub-center. And 5 villages has been fixed because it was seen that the movement of the ANM and the field workers were comfortable along a radius of covering a 5-mile, 5-village population, that is 5,000 population. Beyond that, the work would suffer and the coverage would become even less than 30%. And along with the paramedical staff, the primary health center also has medical officers. Thus, the primary health center functions as first contact between the community and the doctor. Now, CHC is actually the FRU for the 4 PHCs offering specialist care. Now, CHC is the FRU for the PHC, and PHC is the FRU for the sub-center. So, we start from the baseline sub-center, then the primary health center, then the CHCs, and then the apex or the tertiary hospital. It lies at the secondary level along with the sub-district and the district hospital. And at the community health center, patients actually get specialized medical care in medicine, surgery, pediatrics, obstetrics and gynecology, and those cases which require more specialist care are referred to the district hospital. Now, the district hospital is an essential component of the district health system and functions as a secondary level of health care. And every district is also expected to have a district hospital linked with the public hospitals and health centers down below the district hospital. So what happens is that we are setting up a referral system between each and every medical service offering unit, whether it is a CHC or a PHC or a district hospital or a sub-district hospital, and of course the apex hospital. At the at the head of the triangle lies the medical college, and the apex institutes lies at the very tertiary level of healthcare and healthcare delivery system, in which specialized consultative care is usually provided on a referral from the primary and the secondary medical care. Now, specialized intensive care units, that is advanced diagnostic support services, and specialized medical personnel on the key features of tertiary healthcare is important. So, what are these specialized intensive care units? And these actually have to be given from the medical colleges, wherein you have the radiology department, you have the surgery department, you have the burn units, and so these will give diagnostic support, and you will have specialized medical personnel to look after the people who reach up to who need treatment at the medical college and at the apex institutes. Now, points to be considered while selecting for operationalization of the first referral units. That is, it must have a minimum bed strength of 20 to 30, and a fully functional OT is required. A fully operational labor room is required. An area equipped for newborn care in the labor room is essential. As soon as the labor takes place, the newborn can be wrapped in the sterilized sheet and can be put there in absolutely in under the eyes of the surgeons operating and under the eyes of the person who are looking into this. A functional laboratory with facilities for all essential investigations. Blood storage facility is very important. 24-hour water supply, arrangements for waste disposal, regular electricity supply with a backup is essential, telephone communication, and ambulance. Now, these are all absolutely important, and these are the infrastructure needs which are essential for considering what you want to make into an FRU, which that is a fully functional first referral unit. Now, what is the selection of sites? The objective of ensuring proper selection should be to develop a network of 3 to 4 facilities in the district in such a way that these, together with the district hospital, can ensure that all emergency cases in the district can access the nearest facility within a maximum travel time of 1 hour. Now, this is the important part. That is, it should be at such a place and it should be at such a route, it should be so approachable that a maximum travel time of 1 hour from the nearest facility, they should be accessible. So that means it should be accessible, it should be easily reachable, and the officers must be so ready so as to accommodate the patient arriving within minutes of his or her arrival. The whole team will set into action. So, therefore, once again, the objectives of ensuring proper selection should be to develop a network of 3 or 4 facilities in the district in such a way that these, together with the district hospital, can ensure that all the emergency cases in the district can access any one of these 3 or 4 facilities within 1 hour. Now, services provided at the FRU. Most important is, of course, the OPD. OPD runs regularly, and OPD will consist of medical, surgical, pediatric, and the OBG and the dental care OPD. Then we have the indoor facility. For the above services, their patients should be admitted because we have 30 beds. Anesthetic services are there in case surgeries are needed. Neonatal care and obstetric care services are essential, and investigative procedures will include ultrasonography, X-ray, pathology services, which are very important. So it's like a miniature hospital. And control of epidemic, endemic, and communicable disease program, very important, since all these programs have to be rooted into the rural areas or into the periphery through this FRU itself. And all the national programs in the CHC is to be integrated with all the existing programs. Um, Not to forget the reproductive and the child care, which will include actually mother and child care, immunization, family welfare services, including laparoscopic services, and of course, the emergency services should include offer first referral unit, would include medical emergencies in case a person has high fever, is having fits, or he has a pain in the abdomen, whatever it is. He may be even have a mild heart attack. So these would come under the medical emergencies. The 24-hour surgical emergencies would also be admitted, operated upon, and looked after. 24 hours delivery services, including normal assisted deliveries and cesarean sections. Then the care of the newborn, routine and emergency care of sick children, safe abortion services, most important, and medical legal, because we are now talking of the rural, these FRUs, which are mostly based on the borderline of the city and the rural areas. So, and whatever be the case, medical legal cases do spring up as accidents or even strikes, criminal cases, and so therefore all these will have to become to be treated at the FRU and the medico legal filed accordingly. And most important, ninth point is the 24-hour ambulance service is a must, because we do not know when since this is an emergency care producing unit, providing unit, therefore this 24-hour by 7 ambulance services are an absolute must. Now, what are the emergency equipment kits which are being provided under the child survival and safe motherhood? The standard surgical set, that is instruments. You have the CHC standard surgical sets, IUCD insertions, then you have the normal delivery kits. Standard surgical again set for 4 and 5 and the 6, plus the equipment for anesthesia, and most important, equipment for neonatal resuscitation. And this because what we want is at the end of the delivery, at the end of the tunnel, there should be a safe mother, and that is what we are advocating under child survival and safe motherhood. At the end of the work today, we must have a safe mother and a safe child, and they must go home with proper instructions. Now, what are the human resources who are going to work at these FI? A minimum strength of at least 4 MOs who are either qualified or specially trained to work as surgeon, obstetrician, physician, and pediatrician. Adequate number of nursing staff to work in the OT, labor room, and the inpatient department. MBBS doctors should be trained in life-saving anesthetic skills for emergency obstetric care. Provision of other support services like blood storage, laboratory services, pharmacy services should be planned primarily on the basis of multi-skilling and redeployment of available paramedical staff. Financial and financial autonomy. FRU's operationalization is not just about more equipment and funds. It is actually empowering the facilities to respond to emergencies. So, if the FRU doesn't have a particular service, it must be able to hire immediately an effective service provider from the nearby areas. So therefore, you hire locally available specialists or paramedical workers from the private or the NGO sector in case of need. Then make the local arrangements for the referral transport and generate resources locally, and outsource non-clinical service. Means you have the doctors to look after. You don't have a doctor, get a doctor from the outside and bring him into the system, because what is more important is that the patient care is more important. And for non-clinic service, like you need a car to take the person to a higher referral unit, so you outsource. You get taxis or you get other cars. Referral transport, appropriate referral transport from the periphery to the functioning first referral unit, providing emergency services. also from the FRUs to again to the higher district and tertiary level institutions. So these transports must be available and referral must be there. State governments will have to develop administrative mechanisms to facilitate transportation of patients from the fields to the FRU. And to summarize, healthcare delivery in India has been envisaged at three levels, namely the primary, secondary, and the tertiary. The secondary level of healthcare essentially includes CHCs and the sub-district hospitals, including the FRUs. The CHC is designed to provide referral healthcare for cases from the primary health centers, and for cases in need of specialist care, they approach the center directly. Now, CHC is normally a 30-bedded hospital. It provides care in the four fields of medicine, that is medicine, OBG, surgery, and pediatrics. And in case it is needed, IUS is there, that is the indigenous system of medicine. So, to round it up, CHC is an all-rounder first referral unit based at a proper situation in order to help the patients as and when they come. Now, for CHCs and sub-district hospitals to function as FRU, they must have emergency, obstetric and newborn care. Blood storage facility must be there. They should inspire of an adequate infrastructure at CHC. Many times it does not function as a FRU. The main reason behind this is that actually the lack of specialist doctors who are posted at them. So government should outsource the specialist doctors from the private or the NGO setup, if not recruit them. This will actually join hands in making an FRU functional, operational, and set according to the guidelines which are essential for running a good FRU. So thank you for listening to